Good evening, everyone, and welcome to the No Fear Work Package 4 webinar on vaccination. We would start and people will be joining us as we go ahead. We have a wonderful webinar this evening. We are very privileged today to have some very, very special guests. We have the Israeli ambassador and deputy ambassador in Buenos Aires. We have with us the Israeli ambassador in Santiago de Chile. We have with us colleagues from the United States, the Canadian Red Cross, the Austrian Red Cross. So it's a really global webinar about the lessons observed so far from the vaccination campaign. I would just start with a very short overview about the No Fear project. Here it is. No Fear project is the project funded by the European Commission under Horizon 2020 with the idea that the acute healthcare system or market is extremely fragmented between many different suppliers, public, semi-public, NGOs, private, and of course then we have the suppliers and we have the academia which is involved and the interaction with many other actors, as some colleagues from the United States are always telling me, and I think that they are absolutely right, that especially the pre-hospital care people sometimes want to be part of the healthcare system and sometimes want to be part of the public security system. And we actually dance a tango there, moving from there to there as it fits us, and they're absolutely right. So we are about a network trying to bring together all those many different actors, sharing information and trying to do making sense together. As a project, we are organized along 3 pillars: the acute care of patients, which our friends and colleagues from Crimedim, from Policlinico Gemelli are leading, and they will be presenting this evening. Work Package 5, dealing with the training aspects, our friends and colleagues from Cremedim, and us in Magen David Adom. My name is Chaim Wafalovsky. I'm the Disaster Management Coordinator of Magen David Adom in Israel, and the lead for Work Package, the leader for Work Package 4. We are leading the operational side of this activity. So this webinar is about sharing. I would like to emphasize that we are in a very preliminary stage of the work in COVID in general, and Work Package 4, Project No Fear and Work Package 4 have done a lot around COVID. We have shifted a year ago our attention to the COVID operation, and what we are trying to do is learn one from the other, understanding that only by sharing our learnings we are stronger and we will be able to do some good. This is why the presentations today are very preliminary. They are not an official communication by the organization. I would like to stress that again. It is what we as human beings involved in the operation, as persons involved in the operation, have seen so far. It is not an official communication by any of our organizations. We have not gone through the process of validating our thoughts at this stage. So please bear that in mind. And at the end, for those presentations, and not all the presentations can be shared, those that we have that we received their approval will be shared later on the No Fear portal. And this is the opportunity to invite you to join our No Fear portal. Professor de la Corte, are you here with us?
Yeah, sure.
If you would like to say some words of welcome as our coordinator.
Yeah, thank you very much, Chaim. It is my pleasure to invite you to this very interesting webinar. I thank very much Chaim for having organized it. And I will listen. Unfortunately, I can't give a talk because we are really, really deeply involved in clinical management, and I had no personal time to dedicate to a PowerPoint presentation. But I can assure you that we have very bad times here in Italy too. I was vaccinated, so at the end of the year. So I'm very happy to understand which are the news and what will be my future also, because I ought to receive the second dose in a matter of 10 days. So I hope that your experience reported in this webinar will help also us to know something more about what is your activities in your specific hospitals and country. So thank you very much for having organized this seminar, and also thank you very much from the deep of my heart for all the people that will have a talk during this webinar. It's up to you.
Thank you very much. I will let you know my second vaccine is on Tuesday, so I will let everyone know. Just to mention a very special group of guests that we have here today, the colleagues from Belgium, who are at the phase of planning, and we thank them for joining and for their willingness to listen to us and learn from our experience. So without further ado, I will hand over to Leslie. We will have Leslie from the United States, and Hilary from Canada, Professor Daniele Gui from Policlinico Gemelli in Rome, in Italy, Dr. Catherine Bertrand from France, David, sorry, I cannot pronounce your last name, from Austria, myself, and then we will leave some time for some questions and answers. I'm sure there will be a lot of questions, so we will give time to that. So I would ask our speakers to stick to their 10-minute presentation. And also I would like to point out that this webinar is about the organization of the operation. So we are not going to discuss the medical technical parts of the vaccine and what is a messenger RNA and how it works and what are the pros and cons of a messenger RNA compared to a dead virus vaccine. This is another area, and it will not be discussed here today. So now, without further ado, Leslie, please, the floor is yours.
Good morning from the United States. Good evening to everyone else. I am honored to be part of this esteemed panel, so thank you very much. My background, as you can see, is EMS. I'm also a nurse and been involved in the Illinois planning process and the national level. My talks are going to just kind of give you a little perspective of the vaccine, what we received in the United States, how we planned for it, and looking at Illinois' experience and some of our observations. I don't have a lot of solutions, but I have a lot of observations. Next slide.
I think that this is a key observation for all of us. We have a lot of observations and we are trying to figure out better.
Right. All right. So United States received about 13 million vaccines. We were anticipating initially 20 million. So already we were starting short. People so far that have received the first dose is about 5 million. Again, that is below our expectation that we anticipated, but that's where we are as of January 4th of, I guess, 2021, not 2020. Next slide. The priorities that we received, like everyone else, is for phase 1A, which is healthcare personnel. Again, this will come out under our observations, but this became an issue because defining who in the healthcare personnel should receive it varied state by state. And then long-term care facility residents. 1B was our frontline essential workers, which were first responders, law enforcement. Again, this did become an issue, and I'm going to share one of the articles with you about this, is because many of our first responders respond to EMS calls, but weren't licensed as EMS responders, and yet they were told to, stand down, that they would be with 1B, and then 1C, which I won't be talking about today. Next slide. So in 2017, the National Association of State EMS Officials did an EMS assessment. This is all the United States and territories, what they have in their areas for EMS. So we're looking and planning for EMS and vaccination. We have more than 8,200 local EMS agencies that respond to 911 calls, utilizing over 73,000 ground vehicles. It can be air, ground, including fire companies. Local EMS agencies responded to, and this again, going back to 2017-18, about 28.5 million 911 dispatches every year in 41 states. That does not include interfacility transfers. This is 911 calls. So again, so we're looking at a lot more when you look at interfacility transports. And then there's more than 1.3 million licensed EMS personnel, including the 50 states, the District of Columbia, Puerto Rico, and the American Samoa, and actually Guam also. So we're looking at quite a few EMS personnel. Again, these should be considered frontline workers under the 1A across the United States. Next slide. As we looked at Illinois and as we started planning, we had to look at what our numbers were based on the vaccines we'd be receiving. Our healthcare workers, and those were hospitals, is about 650,000, including then also EMS personnel, and that's licensed EMS frontline workers on the ambulance. Our long-term care residents was about 360,000. And again, there's some variation in these numbers. Essential workers and first responders, which would include law enforcement and fire, is 1.2 million. And then over 75, 800,000. High-risk adults with comorbidities was 2.8 million. 1.1 million for ages 65 to 74, 700,000 for over 60 to 64, and 700,000 for other essential workers. It could be like your grocery and other folks like that. So those were the total numbers we were dealing with as we were planning for our vaccination rollout. Next slide. So how we distribute, and this is based on Pfizer. What we determined was we looked at the highest death rate for COVID patients by county. And then if there was a hospital that was in a county that had a local health department, they also were given a priority. And the hospitals with the highest numbers of COVID patients were ranked highest. And that's what we based our numbers, who would get the highest numbers of the distribution. For Moderna, we looked at the allocations going directly shipped to either local health departments, and then we later on changed it last week also to hospitals can get the direct shipment also. And they were actually leading the level based on the numbers that they submitted to us of potential personnel that was for 1A to receive the vaccination. Next slide. So how did the distribution go? Let me preface by saying we thought we were going to get a lot more than we initially got. So Illinois was to receive 102,000 vials of the vaccine. Of the 102,000, 20,000 was going to Chicago specific. So we only received for the rest of the state 80,000. And then you could see the numbers for those that received the initial first dose vaccine. That was as of 2 weeks ago. We did expect to, like I said, receive double what we thought we were going to get. And we're now expecting 580,000 of the Pfizer and Moderna to vaccinate 4.6, to vaccinate the entire population, when really, in reality, we're only going to be able to vaccinate about 4.6% of the state's population. So looking at the total number, if we were to go with just based on what we're getting, we're only going to be able to get 76% of healthcare workers in this first wave of vaccines. That's for both Pfizer and Moderna, based on what we received. Next slide. So how did we determine who's going to vaccinate who? So for our long-term care patients and staff, we have a contract, and this is across the United States, and we actually implemented in Illinois too, Walgreens and CVS pharmacies. Staff from that pharmacies and pharmacy students would come out to the site to vaccinate. Now, many of the long-term care facilities, if they had available nurses, they also did the vaccination. But we relied a lot on this contract with Walgreens and CVS pharmacy. For critical hospital staff, those are involved in direct patient care, hospital personnel would give their own vaccines or their pharmacies would give it. EMS personnel, and this is where we have, a little change here. Our EMS personnel could be vaccinated by their own, by paramedics, by advanced EMTs, EMT intermediates, local health department, or nurses. When it comes to fire suppression involved in EMS, those that are licensed, we also wound up working with one of our county health departments and with some of our partners. Jewel is a grocery store, an Osco pharmacy, if you have a license, you can show up and get vaccinated. This was really helpful, especially in the collar counties of Illinois, to help with the numbers for vaccination. We determined in Illinois that first responders would include firefighter and law enforcement that are involved in EMS care, and they have direct patient care to that. This is not consistent across the United States, which I'll get to later on. Next slide. So ESO, which is one of our data companies, did a study, and I thought this was actually very interesting to share. This was published in December 18th, 2020. So EMS, they have 9,900 encounters with those diagnosed as COVID-19 patients. And that occurred just between October 1 and November 30th of this year. On an average, EMS stayed with a patient 30 minutes. That's including transport time with these patients. And if you look at the cubic feet of an ambulance compared to a hospital, you're talking 186 cubic feet within the hospital that they're spending time with a patient versus the 900 in a hospital, which makes them have a significant exposure risk other than healthcare personnel. Next slide. So this was a chart that they looked at in looking at the average scene time, average transport time, and then the exposure time. I think this really outlines how exposed EMS personnel are to COVID-19 patients and how they should have been considered really at the forefront of receiving 1A and being included at the priority to get vaccinated from the very beginning. Again, I'll show you that when we talk about observations as one of the issues. Next slide. So vaccination for EMS, this is in Illinois. We work with our local health departments to get EMS in our EMS hospitals involved in vaccinating EMS personnel. Our vaccination include for EMS personnel, private, public, and volunteer EMS. As we said, our EMS was considered critical care for our providers, and that they did spend a significant amount of time with the patient, even though it's not the same as a nurse in a hospital who has 8 to 12 hours per day as a shift. As I said before, fire suppression and law enforcement that were licensed as EMS personnel also then were considered part of the critical care program. Next slide. So how can EMS become vaccinators? This is in Illinois what we required. We sent a memo out to our local EMS medical directors in September as we started planning for vaccinators. We told them that paramedics can do it, advanced EMTs, and we still have EMTIs in Illinois, but they must function under the EMS medical director's authority to become vaccinators. They must submit a plan to Illinois Department of Public Health to be approved. They have to submit who actually is going to be vaccinated. It's going to be paramedics. We have pre-hospital RNs or AEMTs. We did not in Illinois allow EMT-based to become vaccinators. The level provider has to be approved by the local EMS medical director. They have to have a written policy about vaccinating, administering it. They have to submit a training program and a waiver if it's beyond their scope of practice. And then they have to do QA on this program for anyone they vaccinate. Next slide. We submitted to them a COVID-19 vaccination provider packet. It's about 45 to 50 pages. It includes fact sheets, it includes forms, anything they would need to become a vaccinator and a provider for that. This went out to anyone that was going to be doing it in their community. Next slide. We also let them have a simple, easy flyer that talks about both the Pfizer and the Moderna, just that they would have posted and available for them. So to remind them of what we were looking at and any questions asked or answered, especially when you look at side effects, because there are a lot of questions that came up about that. Next slide. And finally, this was for the vaccinators. We did just a simple technique that we made every one of the EMS personnel receive this in order to become a vaccinator for their local area. Next slide. So then we received the first Pfizer vaccine. This was at one of the hospitals, as you can see, I'm there. They received the vaccine. The vaccine was initially shipped or transported by the state police from a warehouse to a local hospital. It was then picked up by the surrounding hospitals and local health department. It had to be signed off, it had to be counted, and it had to make sure that the temperature was noted on the outside of the box to make sure that it was in the right storage that they needed it for. This was us receiving at one of the institutions. Next slide. So what went well? Okay, this is my short list compared to our observations. The definition of first responder, I think for the most part, there was consensus about being EMS, fire, law enforcement, those who did direct EMS response. Where there was a difference is where you included dispatchers. Although they didn't do direct patient care, we would be lost without them. The training of EMS personnel across the United States was great. They had training programs, they were all educated on what to expect and side effects. States allowed all levels of EMS personnel to vaccinate. Like I said, here in Illinois, we did not allow basics, but many states allowed any level of EMS personnel based on training and local medical director authority to become vaccinators. We received great communication from CDC that went to the state and then went to the local level and was updated ongoing. Initially, many of our sites, vaccination sites, wanted an ambulance standing by for side effects. Again, this was really putting ambulances out of service, and with the numbers climbing, this was not working well. Many of them finally went to keep maintaining EpiPens and Benadryl at the site, and if there was a severe reaction, calling 911. This really was actually a great way to deal with at any type of allergic reaction. Working with the hospitals and local health departments to include EMS really was well received. Partnering, as I said before, with Jewel and OSCO to provide vaccination was great. And then working with our partners at the national and federal level in order to prioritize and so that EMS came up with one voice. If we had issues, EMS met, we just discussed it, and then we went with one voice to voice our concerns. And then finally, working with our international partners of sharing of information. You know, it's so nice to know that you're not alone in this fight and in all the issues that we're dealing with. So this was really helpful discussing what our priorities are and what was going well. Next slide. I'm just showing this. This is what we provided for our private providers for our local area in Chicago to show what our private ambulance providers, the numbers that they were dealing with and how they had to vaccinate so they can start planning as they look at how to allocate the vaccine. Next slide. So issues, concerns, what went so-so, okay? Some EMS providers were skeptical about getting the vaccine. You know, they hear horror stories about allergic reactions, they're not sure. And I gotta say, we're probably only about 30 or 40% vaccinating local EMS providers. And that is a concern because we really wanted to get much higher, and yet we're not gonna mandate it. That ambiguity of the amount of vaccine that the hospitals would be getting. You know, we were told one center amount, and then we wouldn't get that amount. So now the hospitals had to go back to the drawing board to identify critical people that they would vaccinate and those that they would hold off on. There was some confusion by some of the EMS personnel of who they should vaccinate. Should they go to a local health department? Should they go to the hospital? Should they have their own people vaccinate? There was never a consistency on how this should go. We also have a concern, although we don't know yet what will happen, of a second dose. If a provider gets an allergic reaction, are they going to come back for the second dose? Will they remember to come back for the second dose? Will they lose that card that says come back on this date? We don't know. We're waiting to see. Many first responders were included in 1B, and should they have been 1A? So I will tell you, it is not consistent across the United States, is that fire suppression law enforcement that do respond to EMS but not licensed as EMS personnel. Some are including them in their 1A, some are not. There's not a consistency, and there was nothing guidance on a national level of what we should do with these personnel on how to count them. Then again, as I said, lack of consistency of who gets the vaccine first. So then decreased number of vaccines for the first round anticipated, so EMS came after the hospital personnel. So some areas were doing all their hospital personnel the first 2 weeks, and EMS was going to come after that, which caused a concern for many of our EMS providers. And then complacency after they receive the vaccine for personal protective equipment. You know, we tell them everyone should be a COVID suspected patient, but once they start getting the vaccine, are we going to see complacency of wearing PPE? Then the importance of good communication with one message and a process. Next slide. I'll try to speed up a little bit too. If EMS personnel would get fever or chills after a vaccine, should we quarantine them pending a negative COVID test because we didn't know if they had been exposed or not? I think, to me, one of the biggest issues was that we have a lack of mechanism of collecting data to identify the number of EMS personnel to be vaccinated across the United States. We have no way of knowing how many have taken the vaccine. Then there's a lack of understanding at the local level. Some of the local health departments say, well, they have a medical director, they're going to authorize EMS personnel to vaccinate. They can't do that. It has to be those local EMS medical directors that are responsible for EMS. Confusion on some of the dosage. Some vaccine had 6 to 8 dosages. Well, now the second round, are they only going to have 5 dosage? And what do they do if they don't have enough? And then just the launch of the whole program. Next slide. And this is what I talked about the inconsistencies. This was published, the slide before that, from Reuter, and I won't go into that. You can read that on your own. But it talked about an inconsistency about identifying priorities for who is responsible, including the firefighter versus EMS. And this was published December 30th, 2020. And you can look that up to see that. And next slide. Other national issues is the lack of some places not having the deep cold freezers that is needed for the Pfizer. And then in some areas where the Indian Health Service locations are very remote areas, how to get them to them? Are they going to helicopter drop them in or civil air patrol to use them for mission specific to get it to the local Indian Health Services? And then some changes of when they would be receiving the vaccine. They think they get it one day and then we're told, oh no, you're going to get it now this day. So they have to go back to reallocating and identifying a process in place. And then some of the PPE areas of response were not being vaccinated administration, overtaxing what limited resources we had. So they're using all the PPE and contact tracing for this and not having it available for some of the EMS transports. And then really, although we're told that we're going to get it, but there's a lack of funding to support the vaccination clinics and the programs for everyone. Again, they said that we're going to get grant funding. We haven't heard, and this is across the United States, that this is causing a concern, especially because many of our states are already in budget shortfalls from what the COVID has done to our budgets. And last slide. And just to say safe and Happy New Year to everyone. And sorry if I took a few minutes longer, but this was just a great, interesting topic, and we're learning so much. Each day it keeps changing for us on observations. Thank you, that's all.
Thank you very much, Leslie. As always, fascinating. And we will jump the ocean and go directly to Italy.
To Italy. My name is
Professor Daniele, please.
Good afternoon. Just an update from Italy since we are in the middle of the stream. I will tell you what is going on in my hospital, the Fondazione Policlinico Gemelli in Rome. I want to thank the vaccination team who gave me the data I'll show you. Next. In this slide, an update on vaccination in Italy. You see that Italy is presently vaccinating with Pfizer vaccine, and half of the Italian population will be vaccinated in the first 6 months probably, but the next vaccine will be Moderna. And as a last minute news, we will have Moderna vaccine from the next week, and the army will help in the vaccination campaign. The vaccination started in Italy at December 27, and vaccination is not mandatory. Discussion is ongoing for healthcare personnel. Next. The first phase of the vaccination campaign was obtaining membership for the program. We started 3 weeks before the start of the vaccination, asking hospital staff for adhesion through the hospital portal and the special mailbox. A lesson identified is that not all personnel has access to the portal, so a backup system must be put in place. In other words, a dedicated email address. Adhesion was remarkable. Next. In this slide, I'll show you some numbers. Hospital converted 2 ultra freezers for vaccine stocking. A team of 8 doctors, 17 nurses, 8 administrative operators was immediately defined for 2 work shifts of 6 hours a day, for a total of 12 hours a day. And they were trained with blended technique, e-learning, and practical experience. The hospital health direction has converted the hospital ward of 30 beds into a COVID-19 vaccination clinic with contemporary 6 vaccination points. In each point, we vaccinated 6 people every hour after the doctor had carried out anamnesis and collected the informed consent signed by the person to be vaccinated. On December 28, the Vax Day took place with 60 vaccinated people, 35 of whom belonged to the team of vaccinating doctors, nurses, and administrative staff. Since December 31, about 300 vaccinations have been carried out per day, every day, even on holidays. Next. I want to deal with 2 main directives that we followed. The first is not to waste any dose. From the beginning, we took out 6 doses from each vial, thanks to the skills of dilutor nurses. We specifically recruited trained personnel in preparation of cancer drug bags or bags for parenteral nutrition. Next. Second, we made a point to satisfy all those who had booked in a defined day and time without queues or gathering of people. Scheduling was regular, but not tight. People who arrived had a pre-filled questionnaire with vaccinal anamnesis. They went through a medical survey and then to the vaccinating point. They waited for 15 minutes after the shot. Next. We had 6 cases of widespread urticaria, controlled with cortisone and antihistaminic drugs, 3 cases out of 1,000. For the delayed reactions, we have no feedback yet, and we are sorry not to have put up an easy system to help the vaccinated operators to report these online. So we will have this information probably only after the booster shot. And this is another lesson identified for the future. Next. In 7 days, about 2,200 healthcare workers were vaccinated, a third of those who agreed by formal adherence. Moreover, we are realizing that requests are also growing to the observed safety, since no severe adverse reaction has been reported up to now. Staff who refused in the last month is now requesting vaccination. Another positive aspect is that when you design a strategy, you must allow great flexibility with no overbooking. Next. We conclude that all is ongoing, wait, see, and vaccinate for the moment. And thank you from Rome.
Grazie mille, dottore.
Grazie.
And now we will hand over to our friend, Dr. Catherine Bertrand. Please, Catherine.
Yes. Good morning, everyone. So I will tell you about France, and the vaccination schedule. In December, France joined several other European countries in launching vaccination with the Pfizer vaccine. And France National Health Authority unveiled its 5-step plan for vaccinating the public, focusing its initial efforts on elderly residents of care homes. Next. So we have 5 stages. Phase 1 is involving vaccinating the estimated 650,000 elderly residents living in care homes. Phase 2 involves vaccinating people over 75, followed by those older than 65 with comorbidities, and finally, all other people between 65 and 75 years of age. Phase 3, all people over 50, and followed by people under 50 who have comorbidities. Phase 4, people who have been in high-risk contact with known coronavirus cases will be offered the vaccine during the 4th stage. And phase 5, and we are already it will take 6 months. All other people over 18 years old will be granted access to the vaccine in the 5th and final stage of the roll-up. Without also vaccination will not be compulsory in France. Next. So we have many issues. The first one was a lot of people worried about the security of the vaccine supply chain that keeps doses cold during their storage and also during transportation from Belgium, and also so through France after this. And in nursing homes, it is necessary to have a pre-vaccination visit by a GP, and then to wait 5 days after the patient's consent. As a result, in the first days of the campaign, less than 1,000 people have been given the vaccine, compared to millions in other European countries. And the French strategy is considered too slow. Next. So over 50% of French people say that they have no intention of getting the jab. It might seem paradoxical in France, the home of, as you know, Louis Pasteur's pioneer discoveries in immunology, is also one of the most skeptical countries in the world when it comes to vaccines. And where does this vaccine hesitancy come from? People worry about putting something unknown in their bodies and the consequences and side effects. And what are public health officials doing about it? Our French health minister, Olivier Véran, said that officials were taking time on purpose and start with vulnerable people to win people over to the idea of being vaccinated. It's of course a guess. And they decided that no politician will be vaccinated in front of the TV in order to avoid showing favoritism. Next. So it's you know, a mess in media and in communication. For example, Dr. Philippe Juvin, famous emergency service chief at Georges Pompidou Hospital in Paris, say that there appeared to be no national vaccine strategy in France. And he said also, as an individual, I would like to be vaccinated to set an example and show people that we don't die from the vaccine, we die from COVID. And when we don't die, we get severe forms, which are very disabling. And it was this at CV News TV channel. The 1st of January, our president, President Macron, said that we must have confidence in our scientists and doctors, but that there must be no unjustified slowness. Next. So he decided to speed up, and just a few hours before his speech, our health minister said on Twitter, the government had decided to speed up protection of priority public, meaning medical workers aged over 50 would get a vaccine from early January. And in fact, yes, we all get this, you know, since 1 week. And France would open COVID-19 vaccination centers in cities before the start of February, and over 300 centers, so through France in the next days. Next. So we are just waiting for the results, you know, and we should have 1 million of persons that should receive the vaccine by the end of January. And now, after this slow start, media are wondering if we will have enough vaccines. Okay, so as you know, we start with the Pfizer vaccine. We will have next Moderna, and maybe after Oxford AstraZeneca vaccine. So I will tell you more next month. And I wish you a safe, happy New Year.
Thank you very much. I think we will all meet in 1 month from now, especially after we all got our vaccines, and celebrate together some kind of freedom. But now I will hand over to our friend from Austria, David, please.
Yeah, thanks a lot. I will quickly introduce myself and try to stick to the 10 minutes as best as possible as well. So my name is David Ranschuma. I'm working in the Department of Operations and International Cooperation in the national headquarters of the Austrian Red Cross. And I'm going to present the planning approach, our experiences and the challenges from our Red Cross Society perspective. And of course, as a Central European country, which naturally means less practical experience with COVID vaccination, as for example, we have heard from the US so far. So next slide, please. To frame this report, it's important to understand the role of the Austrian Red Cross and have some sort of background and baseline information. The Austrian Red Cross is the biggest provider of emergency medical services, so ambulance services, and only organization that runs an extensive network of ambulance stations nationwide. This means it's also an important player in disaster management, and on the one hand mandated by law, but also obliged to support by law. This naturally involved us in the COVID response from the very beginning. Of course, mainly doing or performing swab testing with our emergency medical technicians and paramedics, transportation of infectious disease patients, and so on and so forth. We are also running the blood donation service, which we could use to provide also laboratory capacities for PCR and ELISA testing during the initial months of the COVID response. And of course, as always, other relevant services we were running on a regular basis, and also during the COVID response, were offering PSS, mobile care for the elderly, which is important for two reasons, as it involves qualified staff, and also it offers access to an especially vulnerable group, and of course all activities concerned with migration and migrants. What is equally important to frame this short presentation is the federal system in Austria, which offers subsidiary public administration and more or less enabling local and regional problem solving in normal, let's call them blue sky conditions, but with its fragmented responsibilities and multiple levels of administration and also politics, there are plenty of actors and approaches on the table during each nationwide crisis. So this led to one of the key learnings of the first months of COVID response and other historical disasters and crises. After sometimes quite long discussions, there are requests for assistance on the shortest notice. This means that our main planning assumption was that you as an emergency service have to be vigilant and very proactive with your scenario development and planning. Next slide, please. Therefore, we did a situation assessment in September last year at our national headquarters, and one of the outcomes was that we were not aware of any well-advanced plans for the next phase of the pandemic, which is the vaccination. As details for the upcoming COVID vaccines were not available at that time, or at least the pharmaceutical information was not available at that time, we decided to take a different approach and develop a generic plan for a whole mass vaccination campaign, as if we would have to run it on ourselves. So from a perspective as if the Austrian Red Cross would have been the main and only operator of the whole vaccination campaign, to cover all the factors that are involved in such a campaign. This draft plan was based on the one hand on our own expertise, but also what Red Cross and Red Crescent societies have done in the past, everywhere in the world, and of course also on federal and national Austrian plans, mainly those that addressed epidemic influenza scenarios, and also epidemic vaccination plans and guidelines from other countries and organizations, for example, Germany, UK, Canada, and WHO documentations. The idea behind this generic plan for a mass vaccination campaign was to have a guiding document for both us at the national headquarters and also for our regional branches, working in a threefold way, more or less. First, it was planned or it should offer planning for any sort of request for assistance. For example, if a regional government would have requested logistical support, you could have simply taken out that part of the generic concept and adapt it to the specific needs. Secondly, it provides the big picture also for decision makers on a regional level, not involved in vaccination campaign planning on a daily basis, to assess whether the plans by those requesting assistance are well thought and sufficient. And third, having this big picture also should allow us to assess in advance where we as a Red Cross society see ourselves and where we are going to actively seek to contribute for an upcoming mass vaccination campaign. Slide, please.
David, 3 more minutes, please.
Yes, for us in Austria, this reflection led to the following areas we could be able to contribute meaningfully. This was mainly operational planning on all levels, utilizing all of our resources out of the ambulance service and mobile care. Possibly also offering access to vulnerable groups and peer groups, or address gatekeepers of such groups, and of course utilize our international network and experience, and also our experience in communication, especially in risk and crisis communications. Next slide, please. Shortly after finishing this draft plan, we were actually approached by the Ministry of Interior to join a joint working group planning for this vaccination campaign. Our initial task was to support operational planning, self-sufficiently vaccinate our own staff, and also support with mobile teams and vaccination centers. Additionally, there was also a request to support the communication campaign and crisis communication. Other partners in this working group were the Ministry of Health, logically, the Austrian Armed Forces concerned with distribution planning, the Federal Procurement Agency for procurement and their online e-shop requesting tool, and the pharmaceutical trade representatives for the actual distribution, the cold chain, and fulfilling all the legal and pharmaceutical requirements. Next slide, please. The initial strategy was to follow a decentralized approach, bringing the vaccine close to the recipient wherever possible. So directly to the retirement homes, care centers, to the institution of healthcare workers and other workplaces, for example, and using existing structures wherever possible. So doctors, nurses, should become vaccinators for their own institutions and their regular clients, and planning should be done by local and regional administrative bodies to the widest extent. What also was important, that they are going to use, that we were using existing logistical structures and the network of the pharmaceutical wholesale. And this whole strategy should have been guided by a mix of a strategy taking into account medical, but also logistical factors, and a purely medical recommendation by the National Vaccination Board, mainly focusing medical factors. So the phases should have been very similar to what we have heard from other countries so far. Next slide, please. So what worked well so far, and what initial ideas paid out? What was really working great was the use of existing structure in regard to the distribution network. So the whole storing, handling, repacking where necessary, and distribution of vaccines was done via existing pharmaceutical trade network and worked flawless so far. So ultra freezers are only used by the pharmaceutical trade, and all the COVID vaccines are stored there and are just defreezed and shipped in time. So there is no need to have any ultra freezers in vaccination centers. Another success was once again our own ability to support on shortest notice, but this learning is not that easily transferable, of course. Next slide. And my last slide to keep in time is listing the biggest challenges we identified in Austria so far. Communication was already mentioned by others, so I'm not going to go into this again. Also, after the first months of the COVID response, political bickering should have been avoided in the planning and execution of the mass vaccination campaign, and also in the communications for it. But to be honest, this is a bit of a pipe dream. Transparency is, of course, a key factor for both the prioritization and also possible side effects and reactions, or those side effects and reactions that actually occurred. Access is key also for vulnerable groups and those that are hard to target with regular communication. And the prioritization was quite difficult, or is still quite difficult, as with these mRNA vaccines, there are a lot of logistical aspects to take into consideration, but they may not always be in line with medical and systematic risk, and therefore the recommendations of prioritization from this perspective. And the last big challenge is also registration, documentation, and monitoring. Again, with the federal states, minimum documentation is ensured on the national level via an electronic vaccination register, but additional data is needed to monitor vaccine uptake and especially predict willingness and coverage in certain areas or within certain populations. And also such a system is dependent or is the baseline for having an active pharmacovigilance monitoring, meaning to actually contact recipients after their shots and ask them if there were any side effects or reactions. So what is happening at the moment is that the key challenge regarding the prioritization is more or less leading to a lot of discussions and changes in the strategy and also in the prioritization that is still ongoing. And there are further difficulties foreseen in the future with changes on the federal level and differences on the state level from state to state, besides the lack of consistency we already have observed so far. Thank you very much, and a happy new year from me as well.
Thank you very much, David. So the last presentation is about Israel, of course. So far, up to this morning, Israel vaccinated 1.6 million persons with the Pfizer vaccine. And basically, this Saturday, the first dose of vaccination will be over, and very few people will get, and additional people will get the vaccine, as at the moment the main priority is to ensure that those who receive the first vaccine will receive the second dose. And we are already this Saturday celebrating 21 days since we started our vaccination operation in Israel. And we had 3 criteria. Persons older than 60 years old and the direct caregivers. And here we are proud to say that 64% of that population has been already vaccinated, and that number will grow up to 70%. Magen David Adom was tasked to do all the long-term healthcare facilities, and by this evening we will finish that operation. So as the data goes into the databases, I believe that we will be above the 70% for the elderly people. The news for the medical personnel, direct caregivers, is not that good. We have an average of about 50% of the direct health caregivers that were vaccinated. Just to give you an idea, on a regular year, 20% or less of our direct health caregivers take their vaccine, their seasonal influenza vaccine. This year, we managed as a country to have 25% of our direct health caregivers vaccinated against influenza. which is considered a huge achievement. So having 50% is on one hand, whoa. The target was a minimum of 70% of the direct healthcare givers vaccinated. Our Ministry of Health wanted 80% of the healthcare givers vaccinated. It's most probably not going to happen. And there are discussions on making the vaccination for direct healthcare givers in a way mandatory. One of our largest hospitals director sent a memo to his staff yesterday announcing that people who are exposed to COVID patients and are not vaccinated will go on a leave on their time, leave time, until they are vaccinated, and it created a havoc, and our medical association already announced that they are against that and they will fight that decision. The conduction of the vaccination was done mainly in hospitals. And here you can see an MDA volunteer being vaccinated at the hospital. There were also the hubs for vaccination of other healthcare workers, not just directly their own. In Israel, one of our most important components of the healthcare system, which will be critical in a second, is the fact that we all have a mandatory medical insurance, and the actual provider of the primary healthcare and the health medical services are what the United States call the HMOs, the health maintenance organizations, or you would like to call them our medical insurance companies. We have 4 of them, and they were the major hubs for vaccination. And as I said, Magen David Adom, as the national EMS provider, just please bear in mind when I say national that we are overall the country, 9.3 million inhabitants. We were doing the long-term care facilities, and we will be doing that also for the second dose. These are the figures that I have to show you how Israel proudly managed to be the first in the world to vaccinate per 100 persons, and you can see here the doses, and you can see the decrease, and that will decrease in a way because we will not have in the next 3 weeks or 4 weeks many more new people vaccinated. We will be doing the second dose, and according to the media, by the end of mid-February, we should have the large shipment of Moderna vaccinations, and then as a country we will start vaccinating with Moderna, and we expect also some additional doses of Pfizer vaccination. At this stage, the AstraZeneca Oxford vaccination is not planned in Israel for a vaccine. We have a very centralized operation. The whole COVID operation in Israel is run centrally by the Ministry of Health under their special power for emergency situations under the Supreme Health Authority. And in this case, it is the same. They are the only ones it's a central procurement, and they distribute. No one in the country is allowed to buy vaccinations besides the government. There is only one deep freeze storage, which is run by the Ministry of Health. And the important thing is for Pfizer, it is a one-way street for the vials, which means that the vial that went out of the minus 70 degrees centigrade freezing will never go back there. And the moment it went out of the deep freezer, it has 120 hours of survival, and it will go to a vaccination site. And according to the rules set up by Pfizer, it cannot be moved from that vaccination site to another vaccination site. So we basically have 120 hours from the moment it left the deep freeze until we vaccinate a person. And as Professor Gui said, we also have the rule that no vaccine will be thrown away. And I will talk about it. It had a major impact on the way we are having it. So we started with the idea that we have what is called in Israel the pizza tray, which comes with 150 vials of 5 at the beginning. Now it's 6 doses of vaccine in each vial, which means that we had to set up huge sites where more than 1,000 people will be vaccinated. It's good for the larger cities where people would come and be vaccinated. It's not good for the smaller towns and of course for the sites like long-term facilities. So we started with the idea that in the smaller towns, the 4 HMOs were forced, and I have no other word than forced, by our Ministry of Health to open one vaccination site where everyone, regardless of which HMO the person belongs to, will be vaccinated in order to, of course, reduce the waste of vaccines. It worked very well. The HMOs did not like it, but it worked very well when it comes to the usage of personnel and vaccines. And with Pfizer, we cannot do door-to-door. We will do that only when Moderna is available. We were surprised as a country to see how many people are willing to be vaccinated. Part of it is the idea that the Israeli government is going to issue what we call the green card or the green passport, which will allow people to have a better quality of life after they got the second vaccine plus 7 days. For example, the new standards for the Ministry of Health is that if you are considered vaccinated is 2 shots plus 7 days, and you were in direct contact, there will be no mandatory quarantine as it is at the moment for 14 or 12 days. I can be exposed and I will not go into quarantine, and most probably we will be allowed to go to the movies, to the restaurant and other things. As I said, on January 10th, we will reduce dramatically the number of the first shots. EMTs in Israel are allowed to administer vaccine, again, as in the United States, under the jurisdiction or the license of our medical director, Dr. Sturgo, and with a very thorough training program that Magen David Adom has also developed, with both a remote component and theoretical part, and face-to-face when you have to practice. One of our major issues is maintaining the eligibility to be vaccinated, only eligible people being vaccinated, question mark. I will come back to it in a few seconds. As I said, our strong primary healthcare system was a reason why we were so successful. The high acceptance is a major issue. Again, we have some specific groups that are way more difficult. With the ultra-religious groups, it was easier because it was managed in a very smart way with the religious leaders. And in the ultra-religious groups, the moment the religious leader gives the okay, they will follow. No questions asked. The major issue here are groups that have less faith in the authorities, being the authorities, so anything coming from the authorities is considered suspicious. What are our challenges? One of it is the risk communication, and I want to say something about Magen David Adom, where our medical division did a wonderful work producing tons of materials and bringing tons of materials to the accessible to everyone, in a kind of don't listen to me, just read. This is the data, this is the science. These are physicians who are specialists in vaccination, in epidemiology, talking about why is it safe to be vaccinated. And at the end of the day, people read the material and came to you and said, okay, Chaim, I read everything. Tell me, did you get the vaccine? Yes, I did. Okay, do you think it's safe for me to take it? And when you would say yes, they would say, okay, I will take it. So it's a kind of a phenomena that I think that we need to study better, because we are relying a lot on the cognitive processes, on the learning processes, and it looks like personal trust and confidence has a way more important role, which is way more important than we would normally think, especially with people that have some kind of medical training, which is the case for our EMTs and paramedics. We have a major issue with IT and information flow, as I described. Magen David Adom, being another organization out of the HMO, is vaccinating, and the HMOs are sometimes vaccinating one for the other, and all that information, which has to be protected because it's medical information, has to go to the Ministry of Health, and from the Ministry of Health back to my personal medical file at my HMO. And let me put it this way, it is not easy. We are a startup nation, and it is not easy. A lot of good people are working very hard on it, with many issues and less solutions. I think that our major issue is that Israel is going tonight to the third strict national lockdown, and we are with 8,000 new cases on a daily basis. Our healthcare system is saturated with critical patients. But still, in the set of mind of the average citizen, it is over. The vaccinations are here. They don't care that it will take us, we will be doing by Sunday 2 million vaccines. But still, we are 9 million inhabitants. We need to have 70% of our population vaccinated to be out of the woods. So it will take us some more months. But for the people, they don't care. It's the end of the story. Let's party. And that's a major issue. And as Leslie mentioned, having our EMTs follow the strict rules of personal protection, social distancing after the vaccine, it's a major change. Logistics was discussed as a major issue. You can only imagine it's not just about the mobilization of the Pfizer vaccine, it's also, which hopefully will be easier with Moderna, but imagine that you have a site which is doing more than 1,000 vaccinations per day. Professor Gui spoke about it. You need to have a whole system to have people register, have an appointment, and make sure that they are not congregating because it's still a COVID environment. You need social distancing. Our major issue is around the ageability. We had a policy that if at the end of the day there are some doses left, vaccinate whoever is there, just don't throw them away. But in some cases it was abused, and we realized that in some, especially long-term facilities and in some municipalities, to start with, you didn't start your operation yet, and you will have people queuing there because they are the relative of, I don't want to say the mayor, relatives of, and they will ask you to vaccinate them now, and you say, no, I will be maybe able to vaccinate you in 8 hours time or 10 hours time when I'm done with vaccinating others. They would say, no, 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 you did it yesterday, so we want to do it now at 8 or 9 a.m. It got tough from time to time, and this is for those who know the Mediterranean mentality, they would understand that it's becoming a challenge. And of course, having our door-to-door campaign for those who cannot reach our vaccination facilities, it's going to be a challenge, and that's the challenge ahead of us very shortly. So I will open for questions. Just unmute yourself and ask, please, the question. For those of you who don't read Hebrew, it says, this year we are full of hope, and you can see here the hope, but still we have to use the mask, avoid gatherings, and wash our hands. And this is something that the International Federation of the Red Cross and Red Crescent came with the idea. We just made it a Hebrew thing. So please unmute yourself and ask questions.
Hello, good evening. Gauthier Wilmse from Belgium. We will be starting our vaccination campaign soon. And I was wondering, maybe a question for you all. Do you require written informed consent before vaccination? I heard the French are going to do it, but I don't know it for the rest.
In Israel, the answer is only or people who are underage, because we are vaccinating 16 to 18 if in special situations.
So otherwise, no written informed consent.
No written.
No.
The United States does not require any, we're not requiring consent. And at this point, we aren't vaccinating any minors.
In Italy, we require signed consent.
Yes, in Italy we require a consent.
All right.
In Ireland, we're requiring a consent.
In France, it's
Same in Austria.
in France, it's for nursing homes, but it's not a signed consent, it's an oral consent. And for other people, it's just, you know, you come to the vaccination center and you give your consent without any paper.
Basically, the idea that we have here, Catherine, is the same. If you showed up to be vaccinated, that's the way you're showing your consent.
Yeah.
I agree.
Except for old people, because they need to have, you know, to have a pre-vaccination visit with a GP, and after they give their consent, and sometimes it's the families that have to give the consent, so it's more complicated, but it's not a signed consent anyway.
I have to say that in Israel, getting the consent from the legal guardian of the elderly is a major challenge.
Yes, it is. Mm.
Can imagine. Okay, thank you very much.
Yes, please. Hillary is saying that in Canada, the long-term care homes require a written consent. Thank you, Hillary, for that. Yes, please. Any other questions? Just unmute yourself.
Well, I have another one if there's no one else.
Yes, please.
So in Israel, you're ordering your vaccination vials from one central cooling facility, and do you order for one batch for the next 5 days, and then every 5 days you order a new batch, or how do you manage it in your?
At the moment, the order is for a 3 days planning. And by the way, it's not just a vaccine. You receive a package, all included.
All included.
You receive the syringes, you receive the needles, you receive everything. You make the order for 3 days. You receive it on a daily basis.
Yeah.
That's the advantage of being a small country. This is why I was looking into Canada and Illinois, and basically it's like distributing just to Chicago, but they are doing a 3 days planning ahead.
All right. Thank you very much.
This is Peter. Have you
Yes,
had any
Peter.
experience of being able to break down the tray? We're getting trays 1,000 by 6, 500 by 6, and our difficulty is we have to go to acute hospitals and then bring everybody in there from the community healthcare to do them, and then trying to break for individual nursing homes and care facilities. So what experience have you had of breaking up the tray?
Sorry, I skipped that. My bad. The Ministry of Health worked with Pfizer, and now we are allowed to break. We have smaller trays, so we have a tray of 100 and something vaccines. It's basically 100, 500, and 1,000. These are the 3 types of trays, and you can imagine that if you're having a tray of 100 vaccines, it's almost 100. Your life are much easier, and you can vaccinate almost everyone, because bringing 100 people together to one spot makes sense.
And what about cold chain delivery of that 100? Is that directly from the central stores?
Yes.
Or can you break down at lower levels?
It's from the central storage. It's the brave people of the central storage who are working inside those refrigerators and preparing the new trays.
Okay, and are you using your existing vaccination experts primarily? or are you training in new people as well?
The vaccination experts are used for very, very specific tasks, as the vaccination itself is a rather very, very easy, I would say, the technical part is very easy. It's at the end of the day diluting with normal saline and then aspirating 0.3. That's something that is really easy. We need our vaccination experts, especially for the allergic people interview. Because at the beginning, any allergy was a contraindication and it changed, but you need someone who is highly experienced with vaccinating people to interview those people and understand the nature of the reaction and be prepared for that. And this is where we are using, in Israel, vaccination experts are mainly nurses, and they are being used for that and for training. Because diluting a vial with 1.8 saline and turn it around 10 times, that's not that difficult.
Okay. Agreed.
Peter, did I give you an answer?
390,000 today, so we're hopefully do better next week.
Pardon, Peter, I could not. Can you repeat
We've
this?
got to 390,000 nationally today, so we hope to do better next week. It's we can't. Our problem is supply, not delivery.
I can tell you that in Israel, we were victims of our success. We were so proud of 100,000, so we rushed to 150,000, and we were so proud that we are vaccinated 150,000 people a day, and we ran out of vaccines.
Okay.
So the government had to shut down, as I said, the first dose, telling people, sorry guys, we ran out of vaccines, which was not the initial program. But it was a very interesting dilemma in the decision making. Okay, people are willing to get the vaccine, and we have the capacity of giving it to them. Should we allow for more people vaccinated every day? But then we got to the point that government had to tell people, sorry, next week, no more vaccines, wait for the next shipment, which had not happened if we vaccinated only 80,000 a day, and the operation would have taken 3 more weeks. Yes, please, any other question?
Yes, excuse me, I have one other question. In Israel, you mentioned that you were vaccinating everyone, whoever there is, if you have some vials left at the end of the day. And how do you call these people? Do you use social media? You use other channels, website?
The reality is that normally what you would do is, it started with the people that are bringing the elderly to being vaccinated. Because you can imagine that you really don't want your 80 years old grandpa to drive to a vaccination facility. Yeah, so normally there would be someone who would drive them, and you would say, okay, I have some leftovers. Do you want? And since we are living in the social media era, there are dedicated Facebook groups that are notifying people that there are vaccines left here or there, and people will rush there to get their shot.
Okay, thank you. Very interesting. I think we should do it as well.
Chaim, I have a question for you about that.
Yes.
You say that the vaccines are good for, you have 120 hours. Do you keep them overnight and then reopen the site in the morning? Do you go until you're finished for the whole day, the whole tray? How does that work?
If it is a fixed vaccination site, normal refrigerators, -2 to 8 degrees are mandatory with a backup generator. And this is where basically you store you store the vaccines until the vials until they are used, because the moment the vial is out of the, again, I'm talking about Pfizer. The rule is very strict. If the vial went out of the refrigerator, so it means that it is exposed to a temperature higher than 8 degrees. In Israel, that's the case. You have 6 hours. After 6 hours, you have to throw away the vial. So you receive vials, they go directly from the refrigerator in the car to the refrigerator on the site. And you take only one vial out when you know that you have 5 people in queue waiting. We prefer having people waiting for the vial to be open than having a vial open waiting for people to arrive. That's the policy.
Thank you.
This is Dario. I finally am unfrozen. But one of the things we do to ensure that we do not waste any vaccine is that, since we are the New York City Fire Department, we actually have, I was there when we had extra, we looked like we were going to have some extra vaccine. We just pull a unit in from the street. And so we've been calling in fire trucks to just come by, and we get 6 or 8 people and bring them over and we vaccinate them. We do have issue with signing for it. And so at the point that they come in, they say that they accept it, and that's really more for workmen's issues. And we go from there, and we have medical people on scene. One of the things that the city has started to do is actually create the pop-up vaccination stands. So we started off with the central locations at the hospitals. Now they're going to corners, and today we're working with the hospitals to actually establish a local neighborhood pop-up vaccination stand. But we're using the Madeira, which makes it much easier logistically. And so we're working with the hospitals to keep the individuals out of the hospital and not use that as a public vaccination, but actually establish one. And we're looking at one in Upper Manhattan, one of the schools that we have there that are currently not being used. We're going to vaccinate there. And we're looking at we have a ferry station in Staten Island, which is going to become a pop-up vaccination location. So all we need is a place where people can park and go in there. And also, as you said, the issue of people that do not have access to transportation by actually going to their neighborhoods. So we have a pop-up station in Harlem. We have one that's going to go into Lower Manhattan, and so and in the Bronx. And so the idea is we'll go to them now that we've had it. One of the comments I sent in was the issue of logistics. This whole system works on logistics. Medical people do not understand logistics. I am sorry to say. They look at things in a very, very small arena. I have worked many disaster sites at search and rescue, and I can do medicine, and I think I can do logistics until I see the experts do logistics. Those are like military operations. You need to get in the experts that can do it, that can move materials, that can get things going. I don't think our governor or really our medical people truly understand. They're getting caught up on it, and they're starting to understand that these things are very, very difficult to do, to move things and to move things efficiently. And so we've been using those. With the fire department, we're a little bit better than the average. But I think that we're going to start to move into really using more of the National Guard and other things like we did when we put together the Javits Center. So I would go looking at who's the expert in moving it. I can give it, but they're better at moving it and getting it. And again, we do not waste anything at all. We will pull an ambulance in, and that we know had 2 people that haven't got it. Or the other day, we pulled in a rescue truck. That was 6 people right there because we had some left over. We didn't get all of them, but we did not waste a drop.
In Israel, we are doing the same. Please allow me to introduce you a great friend, Dr. Dario Gonzalez, one of the most famous medical directors of EMS in the United States, and he's one of the medical directors of the New York Fire Department. So thank you very much for that. And the last question is from Madalena, and it is about the anti-vaccination Facebook groups. So Dario, I would start with you. Do you have them? And how are you dealing
Yes. well, some of them are in Washington right now. So yes, we do. And it's so hard to try and get at that because we have, you know, and I'm looking at this on a general, sort of a generation basis. We have some people that only get their information from social media. And the problem is trying to unconvince them of what to do. I understand what you're saying about personal contacts. I do it and it's good, but for a large population, I don't see how it could work. So I think that, you know, we're going to just have to keep good messaging. We have to get the right people. And I understand with Canada, with the indigenous people, we have the same problem. We've spent, you know, 200 years abusing them and lying to them. And now we're going to say, trust me, I'm here to help you. And that's a very difficult task to get over. And so we're just working at it as best we can and really trying to use people from the community to try and get that message across to be able to get that. And so
Thank you.
It's a tough thing.
Thank you, Dario. Catherine?
Okay.
I don't know. I don't know really. You know, I am never on Facebook, so I know we have a lot of people against vaccination, and I know they tweet a lot, and they are very, very more than 50% that do not want to be vaccinated. But I think it will change quickly. You know, so I don't know exactly.
Thank you, Peter. Any thoughts on the Facebook thing?
That's correct. A lot of people are just getting certain people are getting their information from Facebook. Our view at the moment is the airlines that fly in and out of Ireland will require people to be vaccinated. So that will have an effect on people because you can't, no vaccination, no flight. So far, we haven't encountered too many people. We have more people who want to be vaccinated than vaccine. And we've stood back from the push to try and get people to take it because we don't expect to be out of healthcare, care of the elderly, the over 80s until the end of February, maybe first week of March, when we move to the general population. Now they've approved the other vaccine. That might get a little bit quicker, but it'll take us a while to get it. But we do have 10, 15% of people who will never be vaccinated. And in my view, Darwin was always right. You know?
Leanne, any thoughts on that?
Yes, we're in the same boat. We struggle with having a anti-vaccine campaign that's quite robust in Canada. And again, as was mentioned, they get all their information from Facebook. And we have some strong public health messaging. And I think it's just, for us, it's just really important that we keep telling everybody we're basing this on science, and we give them all the links and all the access to the science, and trust that hopefully we find strong leaders. And as was mentioned, we have a really good help desk with our Indigenous communities at this time, which we've set up throughout COVID, and we're relying on them very much to participate in getting the message out. That's going to be one of our biggest challenges. They're in very remote locations, fly-in communities, a lot of them only. And so they're high on our list as priorities. They're really high at risk, and we're going to have to find a way to get what we need out there. And I think, as Hillary mentioned, it's going to have to be Moderna just because of the logistics of going into these very remote communities. So it's challenging, definitely.
Thank you. Since we are running out of time, though, I'm having a great time, but in respect of time, I would like to say one thing about these Facebook groups, just to give you an idea. That the first to be vaccinated in Israel was our Prime Minister. And minutes after he got his vaccine, there were posts on all social media that he got normal saline instead of the vaccine, because the vaccine is so dangerous that he will never get it. So even we got even to that point that even if it's public, it's like that. Yes, communication is a major issue, and I think that more than communication for me, it's about trust. And I think that we are struggling with trust with authorities, and also sometimes with internal trusts inside our organizations. And you can see whom is more trusted inside the organization and who is not, or less. Thank you very, very much for all those who joined us, who contributed. We will keep you, of course, we will share the presentations that we can with you, and we will share the recording of the presentations that we are allowed to share, and the minutes of the meeting. And we will invite you to our next webinar that will be announced shortly as part of the No Fear activities. Please register to our No Fear portal. The most important thing is it's a year of hope, as it says there, but we have to wear our masks, keep distance, wash our hands, and we will be out of this together. Thank you so much.
Okay.
Thank you.
Bye-bye.
Bye.
Goodbye. Thank you all.
Bye.
Good luck.
Thank you very much.